Okay, well, hello and welcome to the very first of our IDDP Global Online Harms webinar series here at the George Washington University's Institute for Data, Democracy, and Politics. Today's panel will focus on the crucial issue of vaccine hesitancy worldwide and how it interacts with digital online platforms. IDDP, funded by the John S. and James L. Knight Foundation, has as its primary mission to help the public, journalists, and policymakers understand digital media's influence on public dialogue and opinion, and to develop sound solutions to disinformation and other ills that arise in these spaces. My name is David Broniatowski, and I am IDDP's Associate Director and an Associate Professor in GW's Department of Engineering Management and Systems Engineering. COVID-19. Several new vaccines are increasingly becoming available throughout the world, but as several surveys have shown over the past year, concerns about vaccine hesitancy, spread largely through online misinformation, have the potential to reduce vaccine uptake rates, slowing our ability to fight the pandemic and costing untold lives. This pandemic is not just a national problem, but is a global problem, requiring unprecedented international collaboration if we are to successfully overcome this illness. We have an excellent panel here today to talk to us about the challenges we face and to suggest some ways forward. Dr. Heidi Larson is Professor of Anthropology, Risk and Decision Science, and is founding director of the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. She is also clinical professor of health metric sciences at the University of Washington and guest professor at the University of Antwerp in Belgium. Dr. Larson previously headed global immunization communication at UNICEF, chaired the Global Anti-Vaccine Alliance's, the Gavi's Advocacy Task Force, and served on the World Health Organization SAGE Working Group on Vaccine Hesitancy. The Vaccine Confidence Project is a World Health Organization Center of Excellence on addressing vaccine hesitancy, and Professor Larson's research focuses on the analysis of social and political factors that can affect uptake of health interventions and influence policies. She is particularly interested in risk and rumor management from clinical trials to delivery and building public trust. And most recently, she is the author of Stuck: How Vaccine Rumors Start and Why They Don't Go Away. Welcome, Dr. Larson.
Nice to be here. Thanks.
Dr. Stephen Thomas, Professor of Health Policy and Management and Director of the University of Maryland's Center for Health Equity, is one of the nation's leading scholars in the effort to eliminate racial and ethnic health disparities. He has applied his expertise to address a variety of conditions from which minorities generally face far poorer outcomes, including cardiovascular disease, diabetes, obesity, and HIV/AIDS. He is the principal investigator with Dr. Sandra Quinn on the Center for Excellence in Race, Ethnicity, and Health Disparities Research, funded by the National Institute for Minority Health and Health Disparities. And he has received numerous awards for his professional accomplishments, especially his scholarly contributions leading to the 1997 Presidential Apology to survivors of the syphilis study done at Tuskegee. His current research focuses on the translation of evidence-based science on chronic disease into community-based interventions designed to eliminate racial and ethnic disparities in health and healthcare. And he is particularly interested in how the legacy of this syphilis study at Tuskegee has impacted trust and influenced the willingness of African Americans to participate in medical and public health research. Welcome, Dr. Thomas.
Honor and a pleasure.
Thank you. And finally, I'd like to welcome Mr. Abdelhalim Abdallah, the Crisis Communications Officer for the World Health Organization's Regional Office for Africa. Halim is the Crisis Communications Officer and leading the setup and coordination of the Africa Infodemic Response Alliance and its social media arm, Viral Facts. He is also part of the World Health Organization's COVID-19 vaccine demand and readiness task force in the region, and is supporting with crisis communications for the rollout of the novel oral polio vaccine. As a journalist, Halim has worked with the Daily News Egypt and the Agence France Presse. As a communications professional, he worked with Médecins Sans Frontières in the field in Yemen, Syria, Jordan, and Nigeria, and was also the former head of communications for MSF in Lebanon. Welcome, Halim.
Thank you so much. Great to be here.
Thank you all for coming. So I would like to get us started off with some burning questions here. It's sort of widespread knowledge now that vaccine-related conspiracy theories and misinformation are spread online as part of what the World Health Organization has deemed an infodemic. This has led to significant efforts to debunk or otherwise combat vaccine myths about coronavirus. In your experience, which content is most likely to promote vaccine hesitancy, and how does this vary among the communities with which you're familiar? And I'd especially like to ask this question of Dr. Larson to begin with.
Well, what's interesting is we just, my research group, the Vaccine Confidence Project, has been asked this question, or the question of which misinformation, one, does it really affect willingness to take a vaccine, and what kinds of information. So we recently did a control trial, actually, comparing how people's intentions, for instance, around a COVID vaccine. And it clearly has an impact. It varies by setting. And part of that setting variety depends on the trust levels that people have. In terms of the types of information, we're actually seeing, even though a lot of people who are vaccine hesitant or question or resist vaccines are often put in this bucket of being anti-science. In fact, we're seeing that that's really not an accurate assessment. They really prefer scientific looking things. I mean, even in the misinformation, are much more influenced and trying to draw from science. The problem is it's picking and choosing bits to rationalize arguments, but they're not against science per se. They have a different notion of what the points they want to make. And in terms of the variability of the diversity, there's no quick playbook for people around the world and their vaccine hesitancy. It is highly varied, and I think one of the biggest problems in terms of the information environment right now is that the information that's being put out by health authorities isn't always relevant to the concerns of communities. And those are highly varied. I mean, there's some basic information that needs to be straightforward and consistent when it comes to actual, the schedule of vaccines, why it's needed. But when it comes to how it's presented and in what situations and how you frame it, that really needs to be relevant to the issues in the community. That's the short version.
Thank you very much. And I think one of the main points that you brought up, many people who oppose vaccination don't necessarily see themselves as anti-science. We may not necessarily understand from our perspective over here what their main concerns are. I think that is a key important point. And that really leads us into the next question, which I would like to ask to Dr. Thomas. We live in an era where trust in government institutions seems to be at an all-time low. Perhaps that may have something to do with our inability to understand one another, but it may have to do with our prior history. What can be done to rebuild this trust, and what are some of the sources of the low levels of trust in vaccines that we see today?
Well, first of all, thank you again, David, for the invitation. And I'm so impressed with your French accent. Very, very good. Trust. As you can see in my digital background, no words, but anyone who knows that ribbon and the colors in that window knows that's a sanctuary, a safe place for people living with HIV or caring for those with HIV. We need the humanities. They have not stepped up yet in the sense of the iconography we need to reach certain communities. The work I do in Black barbershops and salons, I hear real raw intelligence. And some of that information has to do with the institutional racism in our healthcare delivery systems, even before COVID. So I'd like to take this audience into a hospital and have them to put their institutional racism glasses on so that we can talk about what they see as evidence of that institutional racism. I want everybody in that audience to cross their fingers as David hits a button or tells a tech person to share a screen. This is a short little video.
I'll know forever where I was on this day because today I received my first coronavirus vaccine. So excited. I'm a teacher. I'm in the School of Public Health. We went to the website and teachers are listed as a priority. I'm here. And maybe it's just a coincidence that the hospital is located on Good Luck Road. So that's what I feel. I feel like I have good luck. I'm fired up and ready to go. Okay, thank you. The election, the inauguration, the insurrection. And then I get my email that I can get my coronavirus vaccine. I mean, all that in a matter of days. I feel like I'm living through history. Is my driver's license right here?
Let's do the thing. Let's do the thing.
We all have our motivations. That is true. And my motivation for getting the vaccine, because I want to be around for the people I love. I want to be around to see graduations. I want to be around to go to the weddings. And unfortunately, even some of the funerals that I've missed because of this.
All right, I'm going to give this back.
I want to be around for all the things that we look forward to in life, and this is one way to turn the corner. I have to admit, I was a bit of a baby. I looked away. I couldn't look at the needle. Tell me when it's over.
It's over.
It's over.
How was that?
You did it already.
I did it already. And I can hardly tell where we did it, but I do right there. Okay?
That's it.
And for being such a great patient, you gave a sticker.
It was painless. I didn't even know it was done. Okay. They laughed. They had the same joy I did in receiving the vaccine. They had joy in giving it to me. I follow you?
Yes, sir.
Okay. So I think that sense of community is the silver lining around this pandemic. My options are
11, 12, 13, and 15.
of February.
Yep.
What's your motivation to get it? But what's your motivation to hesitate? And Tuskegee comes up as the reason why many black people are afraid. That is true, but that's just the surface. Let's go a little bit deeper. And the deeper lesson is that the protections, did you see all the paperwork I had to fill out? That was all to protect my privacy. Those are all part of the legacy of Tuskegee, to protect people. That's the conversation we need to have. And then we need to share why we did it. I think it's real important that we try to give a sense of hope for a better day. I think we can reduce the fears.
Okay, thank you, thank you. Now, you had your glasses on. Did you see the institutional racism? We'll have that in the discussion. And so most audience say, no, I didn't see that. The people who served you look like you. They had the language idiom in the Black community that we're familiar with in the barbershops and salons. It demystified the process. It simplified the process. It says, share what you've done with others. And these reasons to be around for the people I love, to be around for the graduations, yes, the funerals, the weddings, is a communication message I am not hearing from the mainstream. I'm hearing roll up your sleeve, or why aren't you being a good citizen? I'm hearing shaming. We know in other areas that kind of fear does not work. So I'm suggesting that we need to reimagine our whole approach. We need to not just go to the grass tops. We need to go to the grass roots. And in barbershops and beauty salons, It is where social norms are set and maintained. It is where conspiracy theories can grow and thrive, or where they can be tamped down and replaced with evidence-based information. That's what we're doing. And I hope that in this discussion we have today, we can have a much more robust response to delivering culturally tailored information to minority communities. Thank you very much.
Thank you very much. What a fantastic message and what a fantastic video. And I think that leads us naturally to our next question, which is fundamentally about targeting and tailoring, and especially given that this pandemic, by definition, is a worldwide phenomenon. We are dealing not with one community, not with two communities, but with the entire human race, the entire world in which we live, with all of its diversity. And so that means that we're facing a situation in which we really do have to be able to address essentially an international audience with all of the diversity that entails. And so this next question is primarily for Halim, and it is going to focus on the ways in which the COVID vaccine has similarities or differences to other worldwide vaccination campaigns. In particular, despite widespread concerns about COVID vaccine refusal, we know that other vaccines have had a good year in 2020. In particular, the polio vaccine had one of its best years in 2020. What can we do to incorporate insights from the success of prior vaccination campaigns into COVID vaccination? And how can we especially get it delivered to those who are most vulnerable, not just in the richest countries in the world, but all around the world?
Thank you so much, David. It's a real pleasure and an honor to be here. I think when we talk about polio in 2020, one of the key issues to highlight is that we didn't come here overnight. It was a long journey, especially in the African continent and the African WHO African region. Polio has struggled a lot with vaccine hesitancy, and we have, for example, one specific case in northern Nigeria that delayed the eradication of wild polio in the region for about a decade due to a 10 months ban on the polio vaccine in a number of northern states because some religious leaders have said that it's not halal or it's not compliant with Islam. The issue of taking or refusing a vaccine is something that's deeply rooted into people's beliefs, core beliefs, into their politics, into their religion, and all of this. And people have the right to be afraid, and people have the right to question things, and that's something that is key. With the polio vaccine, it was actually an interesting year because in the beginning of the year, we had a suspension of almost all the activities in the region with the first wave of the pandemic. And then we had to catch up on that. And then we had the great news about eradicating the wild polio virus in August. And then in September, we had the rollout of the novel oral polio vaccine, which is addressing another issue. The key with the polio vaccination campaigns that have been ongoing in the region, really we can see that there have been a lot of setbacks, especially in the negative environment and the climate around vaccine trials and negative perceptions about, and several campaigns that are well rooted into a well documented, unfortunately, colonial history as well, and that Africans are not lab rats, etc. These are all campaigns that have been ongoing, and we had a number of influences on social media and in the media and heads of states, etc., refusing them. So what I'm trying to say here is that, for example, one of the key issues that the polio vaccine had suffered or dealt with in the program was some vaccine hesitancy or people being afraid to be vaccinated by the new polio or the novel oral polio vaccine because they think it's the clinical trials or experiments of the COVID-19 vaccine being used. There's a lot of misconceptions and perceptions that need to be addressed, a lot of issues that need to be tackled on Head Start. Many of the key points that we would use or the lessons learned from the polio program is understanding these concerns and addressing them with empathy. Using a show and tell kind of example. We have a massive network of polio survivors in the African region that go door to door during mass immunization campaigns to share their stories with the community. We have religious leaders, traditional leaders on a community level that go door to door. I've been myself in Borneo and I've seen it. It's like a caravan moving around from house to house and to speak to the community and have this empathy. However, in the region, we are dealing with something completely different. We're seeing very negative sentiments against the vaccine that's not even there. It's not even available to the majority of the population. So that's something that we're trying to tackle by making sure that we capitalize on the voices and the people who will receive that vaccine at the start, and these are the healthcare workers and high-risk populations. I think there's a lot more lessons to touch on, but maybe we'll leave it for the discussion.
Thank you very much. And I think what I'm hearing really from all panelists is the need for empathy, the need for compassion, and the need for trust. Now, of course, we are living in a digital world where digital platforms have been implicated as one of the primary mechanisms by which misinformation about vaccines are spread, leading to online harms. And so what I would like to hear from all members of the panel is to what extent and how do we communicate on digital platforms in a way that expresses that empathy? And how is it that current attempts by the platforms to combat misinformation, how can that interact with these attempts?
Well, I can weigh in a bit here because I'm in a lot of dialogues with some of these platforms. And one thing I've seen actually, just from because my research group, we do a lot of tracking of social media and its impacts. And I see quite a different impact in Africa than I do in some other countries. I see more of a shock reaction. It's more explosive and it can be resolved quickly, but it's very different than an erosion of trust in a similar way. And I think that you made me think of it, Halim, because and there's a mimic thing going on with social media right now. We saw when there was a monkeypox outbreak in Nigeria a few years ago, and it was a real outbreak. Somehow a WhatsApp went around saying that the army was coming in and forcing monkeypox vaccines on children. It created an absolute panic. Parents were running to the schools, pulling their kids out of the windows, basically. Some teachers were hurt, actually, and they had to close down the schools. One, the army was not coming in forcing vaccination. Two, there was no monkeypox vaccine. And the issue was they felt like these vaccines could be forced without their engagement, without their approval, without their involvement. And 2 months later, in Madagascar, there was a plague outbreak, totally different outbreak. The same thing happened. Somebody sent a message around saying the army was coming into the schools, forcing vaccination on the children, and a similar kind of outrage happened. Again, it was about feeling like somebody else was controlling them without their involvement. To me, that was the point more. But what's challenging for social media and for platforms, coming back to your question, is these were WhatsApp messages. And these are private networks to the extent that they stay private. And I think when we look at social media, I think clipping off the debunking pieces of misinformation is missing the point. I mean, this is about, I often say we don't have a misinformation problem as much as we have a relationship problem. I do think it's good to correct misinformation to the extent we can, but these are deep-seated emotions, and we need to go upstream. And similarly, in the social media platforms, where they, I think, have a particular role is not editing content per se, because one, they're not health authorities. Two, they have their own, they have to find this balance between freedom of speech and censorship, and finding that line between what's a right, where does the right end and it becomes harm. So that's really the key criteria. Is this causing direct harm? But where they have a key role to play is in reining in the amplification of risk, because and many people who send things don't even know how far and wide, and that isn't even their initial intention, but it goes out there. So I do think in many ways the social media platforms have a bigger responsibility at the algorithmic, the back end, and then we cannot forget the fact that, and I think sometimes in all the focus on social media platforms, we lose the context that people still talk to each other. They still share information at the barbershop. An imam can pick up a WhatsApp message and read it in his congregation. It can go on the radio. We saw in Nigeria, somebody pulled an image of one of the first trial participants for the COVID vaccine in Oxford, cut it out of context, threw it on the Nigerian Evening News, and said she was one of the 10 people who died immediately after vaccination. So I think we need to put these in the broader context. That's not the responsibility of the platforms, but I do think what it does say is we really need a partnership with them.
If I may chime in, speaking of picking up on the partnership aspect that Heidi was talking about, that's exactly what we've been trying to do with the Africa Epidemic Response Alliance. We are trying to build a network of partners, from operational partners, people who have boots on the ground responding to COVID-19, from WHO, IFRC, Africa CDC, as well as the other global partners such as US CDC and the UN verified, UN Global Pulse, and UNESCO. And it's not just about, again, as Heidi has mentioned, it's not just about debunking. Definitely debunking, having correct information in real time and corrections is important, but we don't want to play a whack-a-mole kind of game where we just run after the different misinformation and the claims. And especially in a context where we're living at a time where misinformation for one anti-vax group in the US can impact the public opinion and people's perception around about this topic in Nigeria or South Africa. And one of the things that is quite important to highlight is how can we exactly understand the motivations of the people who are spreading this misinformation, and trying to understand the channels that they're using. And the work around WhatsApp, for example, and exchanging messages over WhatsApp and having staying in the dark as organizations is something that we're really trying to do. And again, just touching back on the experiences that we've learned from polio. And one of the things that we're trying that we have done with this alliance is to start partnerships with the fact-checking organizations and with trusted media partners, where we give them a bit more in-depth kind of understanding of the topic. We can preempt and pre-bunk and understand what are the problematic issues. So, for example, with the polio program last year, we knew that we are saying we are eradicating wild polio, but polio is not over in Africa. And that's something that's quite important and can be confusing to many people. So we need to make sure that people have this information firsthand, and to explain the technicalities, to not just increase media coverage, but also to make sure that we improve the quality of the media coverage. And as journalists, that's something that is key. And for social media, again, it's not just the public or people talking, it's also the media that contributes and publishers that contribute to the narrative.
So just real quick, David, I'm going to date myself. I'm so old. I remember when they had rotary dial phones. I've got an Atari over here. In other words, my point is this: we've let these systems grow up as playgrounds for the frivolous. And now all of a sudden adults are involved. Now all of a sudden serious things are happening. Now all of a sudden it's being used to foment insurrection. Now we're afraid. It's just a tool. Why are we letting the purveyors of trash have free reign when all the good information, the scientific information, is living behind paywalls? That's a different issue, a bigger conversation. But in our communities, they have been marinated in disinformation. And even right now, our conversation is somewhat sanitized because we haven't mentioned that the biggest purveyor of disinformation, actively trying to confuse you, was coming from the White House podium in the previous administration. You cannot expect a local health department or a local village health officer to overcome that kind of power. So as we talk about putting guardrails on, let's not box ourselves in. Let's get more sophisticated and now recognizing that these are powerful platforms to move public opinion. Attitudes are hard to dislodge once established. And I watched in the Black communities I work in where this disinformation was marinating with no countermeasures whatsoever. And now we've got to undo that. And to undo it, I think we have to completely reimagination our approach. So trust matters. And, you may have another question because this is a discussion we need to continue, especially around framing the Tuskegee study. Every newspaper I've seen, it's used as, this is the reason why Black people are not signing up. They're resistant, they're hesitant. But the real lesson of Tuskegee, where the men were denied treatment when penicillin was available, the real framing is that because of Tuskegee, Black people should be a priority. People who participated in the clinical trials in developing countries should be a priority. You can't be the subject of research as human subjects and then be denied the benefit of the science that's derived. That's a violation of the bioethical principle of justice. We're not talking about that. We need to. And last but not least, these kinds of conversations. In my barbershops, they're saying, hey, Dr. T, 3 months ago, the people who said, hell no, they're saying maybe. And the people 3 months ago who said maybe, they're saying, where do I sign up? And the people who 3 months ago said, where do I sign up? They're saying, hey, I've been signed up and nobody's calling me back. I can't wait on the phone for 2 hours on hold. I can't sit there refreshing for 2 hours to get an appointment. We have to point that out and address these system problems because our communities have been burned in the past. The last thing we want is for the sliver of hope they have right now to be dashed in the frustration of a broken public health infrastructure.
Absolutely, very powerful point. And I think that, maybe we can sort of unpack that a little bit more. If we are dealing with an environment that is fundamentally, what we call socio-technical, right? You have political interests that are at play. You also have algorithms that are doing what they're doing that are designed for other things, frankly. And now here we are, in a sense, trying to to react to world events as they happen around us. You mentioned the events of January 6th, for example. What we've seen is that a lot of the platforms have in a sense taken unprecedented action. Certain accounts that previously might not have been deleted have been deleted. Other sorts of information, for the very first time in December, both Twitter and Facebook said that rather than simply downranking, they would start removing content that was opposed to vaccines. How is it that in your experience that interacts with levels of trust in your community? Do people see this as a technique that promotes vaccination, that promotes their interests, or are people reacting in other ways? How are people reacting to what the platforms are doing on the ground?
Well, I think we need to ask ourselves, why is it that a WhatsApp message from somebody somewhere has more power to persuade than the official report coming out of the CDC? We have to ask ourselves, why is it, we have to acknowledge what happens when we actively erode the credibility of our own institutions. In the Black community, there has always been tremendous trust in places like the CDC, the NIH, the Department of Health and Human Services, because of all those things they do for the public good. Nobody would have imagined they could be muzzled. So we have to ask ourselves, how is it that the institutions to which our tax dollars go to protect us can be so muzzled, so marginalized, that a WhatsApp message or a Facebook post can completely have more credibility and more trust than our institutions? I think that's the question. And we cannot build back the way we were. COVID is telling us a lesson. And if we miss this chance to reframe what our institutions are doing, how we build the trust back, we will be here again. And last but not least, it was only in other countries that we saw health officials attacked. In Pakistan and other places where they're doing the village polio work, being attacked, okay? We saw that in this country this time, unprecedented. When Dr. Fauci has to get security, we've never seen that. So I think we have some really fundamental, deep issues to address. And it's more than censoring, it's more than taking posts down. Because I put some posts up that somehow tripped the line. Saying, how did I get my stuff taken down? Let's be careful how we do this, but is the loss of institutional trust that's the big issue where I sit. And that's been organized and orchestrated by parts of the government itself. We've never seen that before.
So I think you bring up a really interesting point regarding how we are now seeing in the United States things that we have seen in other countries. And so I'd like to sort of get a bit of an international perspective on this. To what extent do the events that we've experienced around COVID, to what extent are those a continuation, a natural extension, if you will, of what we might have seen building over the last several years, or to what extent do we see this being really something that's truly novel? Halim, in your experience, if you had to compare what we're seeing now in the United States versus what you've seen in several other countries, for example, in the polio efforts, or in existing COVID vaccine efforts, to what extent are we really dealing with a truly novel situation that is maybe amplified by the actions or the presence of the platforms versus simply a natural extension of something that's been growing for a long time?
I think that's a very interesting point, because I think there's a lot to be learned in the United States from the global programs and the global outreach on immunization. I think there is an urgent, I think what was a game changer in Nigeria, which was the last frontier for wild polio, was having those networks, those community networks, having access to those traditional leaders, having those those frontline workers equipped with the latest information in real time. And having these mobilization efforts is something that I think would be very important to look at and examine for the United States and for other countries for that matter. I think definitely the link between social media and the offline world is really important. It's really intertwined. What happens, one tweet from a very influential person in the United States had caused dozens of cases of hydroxychloroquine poison in Nigeria. So it's very interconnected and it's global. And trying to understand how this information landscape is designed and how the infodemic, as we call it, is flowing from one place to the other is super important. And that's something that we're really trying to better understand how does these networks function, and how does this landscape function. And it's quite important to build a more sustainable ecosystem for healthy information, consumption of information, especially around scientific topics and dense topics such as immunization. And I think Dr. Thomas mentioned something very important, which is the erosion of the trust of the institutions. And why one WhatsApp message can change somebody's opinion rather than the official guidance from WHO or US CDC. And it's as simple as that. Just people don't, and our information and the way we're communicating it needs to improve. And that's something that we need to I mean, there is a problem definitely, but there is also a problem in how we communicate. And WHO has gone a very long way, and of course US CDC and other partners has gone a really long way in kind of integrating messages into different platforms and reaching people through different ways, and especially through the health, through the tech partnerships. But at the end of the day, all of this, we're all trying to understand different parts. We're all like blindfolded and trying to touch different parts of the elephant, try to understand its magnitude and define it, and try to respond to the challenges here. It's really needs a collective effort from all parts of society. It's not just the health practitioners or the health professions. It's not the communications people. It's not just journalists. Everybody needs to come together to kind of make that happen and to change that kind of perception. And that's what we're trying to do in the African region. And definitely that's what needs to happen. That kind of solidarity and collaboration on a society level, also in the global north and in the United States.
So I think one of the really key points that you brought up is the ways in which linkages, transnational linkages that we might not have expected before. For example, one person in one country, even a famous person, saying something nevertheless leading to loss of life halfway around the globe. And of course, we have all been witness to the power of social media to artificially amplify some voices and by comparison suppress others. And so to some degree, people have discussed whether vaccine hesitancy is truly an organic versus an astroturf, fake grassroots kind of movement. And so I would love to hear the panel's perspective on to what extent is this organic? To what extent is this amplified or a consequence of social media? Some of you have already said this is not only the platform's responsibility, but there seems to be a growing consensus that it is in part the platform's responsibility. So to what extent can we say that this is truly an organic movement? And Dr. Larson, I would love to hear your thoughts on this to start.
Yes, it's the question that inspired me to write Stuck. And I I started seeing this epidemic, organic epidemic of questioning and sometimes dissent, but sometimes just questioning around the world when I was leading UNICEF's communication and strategy around introducing new vaccines. And we launched Gavi at the time. This was 20 years ago. Yeah, I'm competing with Steve for the old age award. um, um, and this was 2000 to 2005. And I thought I would be focused on proactive communication strategies. And I ended up getting the nickname, the director of UNICEF's fire department, because we had more and more episodes where we would have people, individuals, communities say, whoa, we don't need that. We're still trying to catch up with our measles. You don't need to keep adding these new vaccines. And being an anthropologist, I got sent out there to figure out what those crazy people were thinking. Um, but the more I sat with people, the more I heard a deeply, deeply human and emotional. And actually, what struck me and why I ended up leaving UNICEF to found the Vaccine Confidence Project, I felt like vaccines were like a litmus, like a tipping point, a canary in the mind of deeper human emotions, relationship with government, politics. There's no way I thought I'd stick with vaccines for 20 years, but it's not because of the vaccines. It's because of all the nerves, the relationships it touches between community, between government, between big business, between, generational. And it's truly organic. I'll never forget sitting with a group of Nigerian mothers during the boycott in Kano State of northern Nigeria, 2003 to 2004. They said to me, you know what, Dr. Heidi, the thing that makes us so angry, I was with a local translator, so this was in Hausa. And I just wanted to hear, I would try to get behind the rumors, because usually the rumors, they would say something that, yeah, it's a rumor, it's going to sterilize us. But then I would say, well, what else is bugging you? And they said, well, you know what? The thing that really makes us angry is when we hear on the radio that we're ignorant. We're refusing the vaccines because we're ignorant. We wouldn't be asking these questions if we were ignorant. And then a similar situation, walking house to house with the vaccinators in Uttar Pradesh, in the poorest, marginalized part of India, kind of knee deep in mud and I don't know what other things. And this vaccinator, a really gentle man, um, knocked on a gate, and this woman opened the gate and said, go away. And he said, well, this is for your children. Go away. And he said, and he was trying to ask, well, why? Can I answer? She said, Uncle, I don't need to explain to you why. No is no. This is my decision. And then she said, I don't have to give you an answer. And as he was walking away, looked at me, and you could hear her as she went away. Besides, you keep telling us you're going to give us all these other health things and they never show up. Why should I do this now? And she sort of said it walking away. But so there was anger in there. There was like, you didn't treat us well before. Why should I give in for this thing? So my long answer to your short question is it's definitely been out there. I saw it. I was in from Africa, India, Tehran, Hanoi, Bosnia, Sarajevo, Ouagadougou. It was everywhere in small ways and big ways. And it was even people in government. It wasn't necessarily, people in remote, poorer communities. People were saying, well, wait a minute, you keep adding more and more and more. And where are we? You never came and talked to us about this.
So, Dr. Heidi, I love that, Dr. Heidi. The history of racism and discrimination in our healthcare system would be easy to ignore were it not so well documented.
Yeah.
And so in our communities, the distrust has been earned, and our aim should not be to disarm them. And Dr. Heidi, here you are giving me an African village story, and I'm telling you it's the same story in the Black barbershops in Prince George's County and Baltimore City and around the country, because they were suffering the health disparities, the underlying conditions before COVID arrived. Now COVID comes. They're saying, where were you then? Where were you when my uncle's getting his legs amputated because of out of control type 2 diabetes? Where were you when we got people in their 40s dying from colon cancer? Plus, you've already drawn blood, made me do surveys for that other research project, and we haven't heard the results of that. So why are you here now? I do not think we should disarm them. There's a reason why there's a certain protection. We have to listen, and we have to stay for the long haul. And a no today does not mean a no tomorrow. That's the lesson I bring back. That just by listening, not immediately correcting, not immediately saying that's not correct, not immediately giving them a one-on-one in virology. When they ask the question, will the mRNA vaccine change my DNA? Don't look at them like they're stupid. We're asking a lot of people, a lot from people. We got to be there for the long haul and translate that information into other formats. We're raising money right now to take the COVID mitigation guidelines from the CDC and turning them into graphic novels where the characters in the novel are the very Black barbers in the neighborhood. Guess what? Before they read the bubbles in the cartoons, they'll say, hey, look, I'm in this. Look at this. They'll start sharing it. A very non-threatening way of building relationship. That's where the sweet spot is. We have to rebuild the relationship. Trust, when people say, I'm sorry, like they apologize for Tuskegee, an apology means I'm sorry from people who weren't even around who perpetrated the atrocity. We need to move towards atonement, which means making things better. And whatever's going to come out of Congress with the new Recovery Act, or whatever it's going to be called, better address these grassroots, not grass tops, grassroots, community-driven innovations. We're at a moment now for brand new ideas. Who will own and control those ideas? And minority communities are doing it right now. They need the resources and support. And I'm holding a mirror up to my university colleagues. When we hear things from the community about the institutional barriers, the oppression in the algorithms, David, we need to go back to our presidents and deans and say, we got to do a better job as an institution. Why are people living in the shadow of our buildings, suffering from all the things we say we're expert in? It's paradigm shifting time. If we can't do it now, when? And if not us, who? I love this format. Zoom means I can bring the community into this space and hang out with Dr. Heidi. That's amazing. I'd love for you to talk to my barbers, you too, my brother, at the WHO. Help the community demystify this stuff. And then use these platforms in the interest of justice.
Yeah, I think, well, I'm with you. And it gets back to what David kicked off the session with, which is the compassion bit. And I was smiling because yesterday there's a big article about some of the challenges with the Black and Asian communities here with their trust issues. And one of my favorite quotes was in this article. They were saying, let's put it this way. When the government talks about, they had locked down pubs and then restaurants, but then they said, well, you can keep your pubs, you can go to a pub if you have a meal with your beer. And so the great debate became that, this person said, so what did they tell about? They're there debating about whether a Scotch egg is a meal or not. What the hell is a Scotch egg? It's like, we don't do Scotch eggs in our community. And then they said, and then it's about closing down the pubs. we're not out there at the pubs. This is in the Muslim community. They're saying we gather in other ways. Use some terms that are relevant to us. I loved the Scotch egg story.
And you know, Heidi, and I can tell from my fellow panel members, you know how to build that relationship. You know how to build that trust. But we as individuals are also part of institutions. I think we also have to be trustworthy. So once I disarm, you know, once the shield comes down, now I'm in my Star Trek mode. Once the force field comes down and they let you in the circle of the family, the circle of trust, we have to be trustworthy. Who might come behind us from our institution, but without the same level of empathy? The community, my barbers can't tell that somebody from the University of Maryland is not from my shop. It's a big place. So people can exploit that for their own interest. Oh, I need to recruit subjects for my clinical trial. I'm going to go to the barbershops, but not through the hard work, the hard trust building, relationship building that has been done through centers like mine and the work that you do. So we have to also, I don't want to be like a roadblock, but we have to be trustworthy. And that means taking back to our institutions what the community is telling us. That means using these platforms to elevate the voices, unfiltered, unvarnished from the community. And that means that sometimes we have to express their anger, their passion, so that the powers that be recognize we do have a bridge to rebuild.
So I thank you all for these comments. This was truly a fantastic panel. One of the quotes that I was writing down was from something that Halim mentioned earlier, which was when speaking to communities, he said they were feeling like someone was controlling them without their involvement. And if there's one thing that I feel like perhaps encapsulates one of the roots of what I've been hearing from all of you, it's that people who may be vaccine hesitant on the surface may be expressing something much, much deeper, something that goes far beyond what can just be addressed by a purely digital approach, but has to take into account the depth of the human approach and has to approach both of these so that we can scale it. And I see Dr. Larson holding up her new book, Stuck, which I believe addresses that.
It's all the stories about what's going on behind the hesitancy.
I love that. You can help me with Stuck in the Barbershop version. I love it.
I love, yeah, I always thought taxi drivers, barbers and hairdressers, actually this is a bit off piste here, but I was based in the South Pacific for 6 years working on AIDS, and the best network was hairdressers because that was all the gay community was all there, and they did better than any of us in terms of both gathering the information and getting the right information back. And we just stood back and watched.
You can learn.
Well, I think we have much more. We have much more to learn. We have much more we can do, but we have reasons to be hopeful. I thank you all for your time and for your participation and for your expertise. And thank you to all who joined us. And I hope you will all consider joining us for our next IDDP seminar series, which is going to be coming up within a matter of weeks. And thank you all once again.